Dear ladies and gentlemen, dear friends, I have the pleasure to respond on the invitation of my very good friend D.Ivanov and to be either present with you throughout this presentation or on site. But anyway, I would like to share with you something about the way I see how we should treat the hyponatremia, since I was involved in this guidelines prepared in 2014 first time, and then recently I also published by invitation of NDT editor-in-chief about hyponatremia updating of the treatment in 2024. So we will start with the content, of course, definition, epidemiology, something about the physiology, types, clinical manifestations, etc., about the treatment. So definition. It's commonly defined as a serum sodium concentration below 135 milliequivalent or millimole per liter. It represents a relative excess of water relative to sodium and mainly occurs due to the water retention or natrium loss, which may be higher when we use thiazide diuretics, and it is induced by them very frequently. The frequency hyponatremia is most common electrolyte disorder. Prevalence is up to 7% in the general population, up to 30% of patients treated in the ICUs, and about around 50% of nursing home residents which has at least one episode of hyponatremia. As I said, most common electrolyte abnormality. It depends from the number of factors, like how we define the hyponatremia, frequency of testing, healthcare settings, patients population. But as you can see on this slide, it's very important to see that we have hyponatremia at the admission, presented at the admission into the hospital, or hospitally acquired hyponatremia, which also happen very frequently. And you see here the total amount of hyponatremia. But let's go for the hierarchy of outcomes. The critically important outcome is certainly the patient's survival, and then being in coma, brain damage, epileptic seizure, osmotic demyelinating syndrome, which depends on the treatment, and highly important are the bone fracture outcomes, falls, and length of hospital stay, of course, which is important as a socioeconomic factors, and moderately important is just serum sodium concentration regulation. On this slide, you see that the lower or the deeper is the hyponatremia, with starting from 110. You have the higher is the mortality, and it's U-shaped. Again, you see here above, this is hyponatremia, above 145. Again, it increases the mortality of our patients. What about the diagnosis and classification of hyponatremia? Mild, we do have when the serum sodium is between 130 and 135, moderate 129 to 125 to 129, and profound below 125. And it may be acute hyponatremia, as hyponatremia that is documented to exist below 40 volts or shorter than 48 hours, chronic, when the hyponatremia exists at least or more than 48 hours. And if we do not have possibility to classify the hyponatremia, then we can consider it as a being chronic, unless there is any clinical or domestic evidence in contrast. Drugs and conditions that might be associated with acute hyponatremia. These are post-operative phases with post-resection of the prostate, or endoscopic uterine surgery post-resection, polydipsia, exercises, thiazide prescription, colonoscopy preparation, using of cyclophosphamide, oxytocin, etc., etc. Definition of hyponatremia based on symptoms. We can have moderately symptomatic hyponatremia as any biochemical degree of hyponatremia in the presence of moderately severe symptoms of hyponatremia, or severely symptomatic hyponatremia as any biochemical degree of hyponatremia in the presence of severe symptoms. And the symptoms which are severe are vomiting, cardiorespiratory distress, abnormal and deep somnolence, seizures, and coma, according to Coma Glasgow score below 8. And moderately severe symptoms are nausea without vomiting, confusion, and headache. About the physiology, I'm not going to tell you a lot because you do have all in textbooks. But what I do assume as an important issue is that we need serum sodium concentration regulation to know how it goes, either throughout stimulation of thirst or secretion of ADH, antidiuretic hormone secretion. And it works throughout feedback mechanism of the renin-angiotensin-aldosterone system and Raymond handling of filter sodium. Stimulation of thirst, which is a center for thirst located in the hypothalamus. When the osmolality increases, it is the main driving force, and only requires an increase of 2 to 3%, and then it is stimulated. Or when there is a blood volume pressure reduction, which is main driving force and requires a bit higher decrease of 10 to 50%. And the second stimulus is of ADH, synthesized by neuroendocrine cells in hypothalamus and triggered by the osmolality of body fluids, a change of about only 1%, and change in volume and pressure of the vascular system that increases the permeability of the collecting ducts to water and urea. As you can see here, the plasma osmolality is increasing, and then the thirst is going along with it, and we have increased the plasma antidiuretic hormone secretion. And on the other hand, how it works with the hypovolemic stimulus, you can see here we do have hypovolemic stimulus to ADH release. We have a blood volume depletion in the percent here, and after above 10 to 15%, we have increasing the plasma ADH secretion in order to increase the blood volume. And furthermore, about the physiology, hyponatremia with impaired normal free water excretion or natrium loss, as we said, that it exceeds water loss. When there is an acute drop in the serum osmolality with a neuronal cell swelling of the brain provokes the responses for osmoregulation, etc. And plasma osmolality, we should know, it's a serum osmolality between 275 to 90 milliosmoles per kilogram. And the calculation is according to this formula, which is taking into account also not only the serum sodium levels, but also glucose levels and urea levels and ethanol alcohol levels. Is there any difference between the osmolarity and osmolality? Osmolarity is number of moles per liter, and osmolality is number of moles per kilogram of solvent. But this is very important issue, effective and ineffective osmoles. Effective osmoles are not the sodium chloride, glucose mannitol in the extracellular fluid, and kalium chloride in the intracellular fluid. And they both contribute to tonicity. And ineffective osmoles, urea in ethanol with effective osmoles, they together contribute to osmolality as well. What is the stepwise approach? First, we measure serum osmolality, and if it is 275 and 290, that is isotonic or pseudo hyponatremia, which is always present with hyperproteinemia, hyperlipidemia, and with low measured sodium concentration. But anyway, the osmolality is normal. Hypertonic or redistributive hyponatremia we do have when there is a higher osmolality above 290, It occurs with the presence of the hyperglycemia, mannitol, excess of another excessive osmol that draws water intravenously, and the true hyponatremia or hypotonic, that is the only hyponatremia, which is certainly with the low sodium levels and low tonicity below 275 milliosmoles per kilogram. So we should confirm first hypotonic and exclude other possible non-hypotonic hyponatremias. And according to the volume status, we should know that there is euvolemic hyponatremia with the H2O increased and sodium stable, hypervolemic with H2O increased and natrium increased as well, and hypovolemic status with H2O decreased and sodium decreased as well. Where do we have in which situations this? Euvolemic, we do have in the presence of SIAD, syndrome of inappropriate antidiuretic hormone secretion with the diuretic use, glucocorticoid deficiency, hyperthyroidism, beer-protomania, and psychogenic polydipsia. Hypervolemic status we do have in decompensated chronic heart failure, in advanced liver cirrhosis and renal failure, and hypovolemic we do have in gastrointestinal solid loss like there with diarrhea and emesis. This third spacing loss, water as we have in ileus and pancreatitis, and also with the diuretic use, Addison's disease, and salt wasting nephritis. Second step is confirming hypotonic of this confirmation of hypotonic and exclusion of non-hypotonic hyponatremia. Most frequently we do have hyperglycemic hyponatremia, and this should be excluded by simple measuring of serum glucose concentration and correcting of the measured serum sodium concentration for the serum glucose concentration if the latter is increased. And which are the effective osmoles which are contributing to this. This is either glucose, mannitol, glycine, histidine, tryptophan, ketoglutarate, hyperosmolar radial contrast media, maltose sugar. In the isotonic or hypertonic, then we can have urea, alcohol, ethylene glycol, triglycerides, cholesterol, and proteins. And finally, intravenous immunoglobulins increased in monoclonal gammapathies. This all can substitute the levels of lower levels of sodium and giving the hyponatremia, which can be caused with these elements. But of course, we should first exclude the hyperglycemia in these cases. Second, hyponatremia with a measured osmolality should be below 275 in order to be true hypotonic hyponatremia, and this should be accepted when there is no evidence for causes of non-hypotonic hyponatremia as listed in the previous table. Which parameters should be used for differentiating causes of hypotonic hyponatremia? Urine osmolality. In a spot urine, if urine osmolality is below 100 milliosmol per kilo, relative excess of water intakes as a possible cause of the hypotonic hyponatremia should be accepted. And if the urine osmolality is above 100 milliosmol per kilo, then the urine sodium concentration on spot urine should be taken simultaneously with a blood sample for interpretation in order to see what is the number of smoles in the blood sample. If the urine sodium concentration is below 30 millimoles per liter, then a low effective arterial volume as a cause of the hypotonic hyponatremia should be considered. And if the urine sodium concentration is above 30, then the extracellular fluid status and use of diuretics for further differentiation and as a likely possibility of hyponatremia should be assessed. Vasopressin should not be measured for confirming of this diagnosis of SIAD. And about the SEAT, because it's one of the most frequently seen condition, with the main criteria, like essential criteria, is if we have effective serum osmolality below 275 and urine osmolality above 100 milliosmoles, clinical euvolemia, urine serum concentration above 30 millimole per liter, and supplemental criteria are the serum acid, uric acid is below 0.24 millimoles per liter, and serum urea below 3.6 millimole per liter. Causes of this SEAT syndrome, you can see there are causes associated with malignant diseases, with pulmonary disorder, disorders of the nervous system associated with various drugs use, and other hereditary, idiopathic, or transient symptoms or causes of this situation. You can see on this slide, diagnostic flow chart. We should first, as we said, exclude hyperglycemia and other causes of non-hypotonic hyponatremia. If there is real hypotonic hyponatremia, we should differentiate whether it is acute or severe. If yes, consider immediate treatment with hypertonic saline. And if no, then we should measure urine osmolality. If below 100, then we should consider primary polydipsia, low solute intake, or beer potomania. Or if above 100, then we should consider urine sodium concentration for further differentiation. And if it's below 30 millimoles per liter, then we have low effective arterial blood volume in situation of extracellular fluid expanded, like in heart failure, in liver cirrhosis, in nephrotic syndrome, or when extracellular fluid volume is reduced, then we should consider either situations with diarrhea, vomiting, third spacing, or remote diuretic use. And in contrast, if the urine sodium concentration is above 30 millimole per liter, then we should consider diuretic or use or kidney disease. If there is diuretic use, we should or kidney disease, we should consider them, and all other causes of this, like previously stated. And if there is no diuretic use or kidney disease, then again we should consider whether there is a reduced extracellular volume, or there is normal, like in situation with SEAT, secondary adrenal insufficiency, like hypothyroidism, and occult diuretic use. And we are coming to the treatment of hypotonic hyponatremia. 4 issues should be considered before the initiation, whether it is asymptomatic or symptomatic situation or disease, acute within first 48 hours, or chronic above 48 hours, and the volume status, EU, hypo, or hypervolemia. First step is to calculate the total body water, which is calculated according to this equation, 0.6 multiplied with body weight. With severe system, we should treat it with these possibilities: lactate ringer solution, which is having 130 milliequivalent of sodium, or 130 millimole per liter, and chloride 109, or 1 liter of normal saline, which contains 154 milliequivalent of sodium and chloride, and 1 liter of 3% hypertonic saline solution that contains 540 milliequivalents of sodium and chloride. I cannot go through all of this, but this is the way how we should measure or assess the need for the treatment with either of these solution. And this is very important, the way how to prepare hypertonic saline solution of 3% in 500 milliliters of sodium chloride. And you see how it works here. You will have this possibly PDF in your materials. And the treatment algorithm for severe hyponatremia treatment would be, if we do have severe hyponatremia with serum sodium below 125, we start with the hypertonic sodium solution, 3%, boluses 100 to 150 milliliters over 20 to 40 minutes. And or it continues infusion 0.5 to 1 milliliter per kilogram per hour. If the sodium increases in the first hour below 4 millimole per liter, then we should repeat this HSS. If sodium is increased with the desired level of 4 to 6 millimole per liter, then we should stop the treatment. If the sodium is increased above 6 millimole per liter, then we should stop first the 3% hypertonic sodium solution, and eventually consider desmopressin 1 microgram subcutaneously or IV each 8 hours with the glucose solution 4 milliliters per kilogram to decrease 1 millimole of sodium with that treatment. First hour management is very important, regardless whether hyponatremia is acute or chronic. So we should prompt IV infusion, as I said, 150 milliliters of 3% hypertonic solution for over 20 minutes. We need to monitor after 20 minutes whether this infusion has increased the level of sodium, and then we should repeat the same therapeutical strategy at second hour or twice in the first hour until a target of 0.5 millimole per liter increase in serum sodium has been achieved. And patients with severely symptomatic hyponatremia, and we should monitor them very frequently, and we should be treating them in a milieu with a close biochemical and clinical monitoring possibility. So if there is an improvement of symptoms after the first increase of 5 millimole per liter of serum sodium, then we need to stop the infusion of this hypertonic saline, but we should still keep the line open by infusing the smallest visible volume of 0.9, so regular physiologic saline solution. And we should go to diagnose the co-specific treatment if possible to manage. And now also to start a diagnosis-specific treatment if available, aiming at least to stabilize sodium concentration. We need to further limit the increase in serum sodium concentration to a total of 10 millimole per liter during the first 24 hours, first day. And in the next day, additionally, we can increase the 8 millimoles per liter of sodium during the second day, 24 hours, or until the serum sodium concentration is reached for the level of 130 millimoles per liter. And then we should check the serum sodium concentration after 6 and 12 hours and daily afterwards until the serum sodium concentration has been stabilized under stable treatment. If no improvement of symptoms after the first 5 millimoles per liter increase in serum sodium, we should continue with the IV infusion of this hypertonic 3% saline and stop the infusion when the symptoms improve or the serum sodium concentration increases for 10 millimoles per liter in total, or the serum sodium concentration reaches 130 millimole per liter, whichever occurs first. Additional diagnostic exploration for other causes of the symptoms than hyponatremia is also a very important issue in order not to misdiagnose our patients, and check the serum sodium concentration every 4 hours if an IV infusion of 3% of hypertonic saline or equivalent is continued. What with the hyponatremia with mild or moderately severe symptoms? then we need to differentiate whether we have hypovolemia, euvolemia, or hypervolemia. If it is hypovolemia and true hyponatremia, then we should measure urinary sodium level. If it's above 30 millimoles per liter, then it's certainly what we can say renal cause, and we should discontinue diuretics. If urinary potassium is low, we should consider fludrocortisone. And if urinary sodium is below 30, it's certainly non-renal cause. Again, we should discontinue diuretics if they are present in the treatment. We should give antiemetics if needed and causative treatment if possible. However, we need for both situations to give supplementation of the volume with a physiological solvent solution up to 30 milliliters per kilogram per day, or oral salt intake in meals up to 9 grams per day, which is also very important issue for this dietetic measure. If there is a condition of euvolemia, like in CEAT, we should exclude thyroid or adrenal disease, drugs, infection, tumors. We should measure plasma or urine osmolality, and we should consider that there is no malnutrition. Fluid restriction should be first implemented strategy if diuresis is below 500 milliliters, or serum sodium increases for below 2 millimoles per liter in 24 hours, we should be satisfied. And from the drugs point of view, we may use loop diuretics initially, and if there is no good response, then we should go with tolvaptan up to 7.5 milligram per day, monitoring serum sodium for eventual overcorrection or dose doubling. In case it's not overcorrected, urea, we can use it for starting dose of 15 grams per day, and nowadays we should also use SGLT2 inhibitors 25 milligrams per day with a sodium intake of 1 per 2 grams per meal and potassium-rich food. And in the situation of hypervolemia, we should again measure urinary sodium if above 30 or below 30 millimoles per liter. If above 30, again, we should consider renal cause, nephrotic syndrome, or non-renal diuretics. And in this non-renal cause, we should consider congestive heart failure, chronic heart failure, and liver disease. And in that case, we should restrict the fluid. We should give furosemide. We should increase the serum sodium with tolvaptan, and we should maybe use urea 15 to 60 grams per day, and SGLT2 10 to 25 milligrams per day. In this situation with the renal cause, we again should consider fluid restriction with loop diuretics if GFR is between 15 to 45, in order to be considered as eligible for reduction of this fluid, and tolvaptan if the GFR is above 30 milliliters per minute, and if GFR is below 15, certainly to send patients to the nephrologist. This was the algorithm to mild and moderate severe hyponatremia. So it has simply to somehow consider as a short, again, recommendation. We should start from diagnostic assessment. We should stop medication if possible, and other factors that can be contributor factors or provocation of hyponatremia. Of course, whenever it's possible, we should treat cause specifically. Immediate treatment with the simul fusion of 150 milliliters of 3% hypertolic saline or equivalent over 20 minutes, with the aim of 5 millimole per liter for 24 hours increase in serum sodium concentration, and limit the increase in serum sodium concentration to 10 millimoles per liter in the first 24 hours and 8 millimoles per liter during the next 24 hours, and thereafter until serum sodium concentration is reaching 130 millimole per liter. Then we should, in the meanwhile and later on, check the serum sodium concentration after 1, 6, and 12 hours of the treatment. Additional diagnostic exploration for other causes should be considered, and the management of the patient as in severely symptomatic hyponatremia if the serum sodium concentration further decreases despite the treatment of the underlying diagnosis. We here have the treatment armamentarium, so isotonic saline in hypovolemic hyponatremia, 23 to 30 milliliters per kilograms, 3% hypertonic saline in severe hyponatremia, especially with symptoms, 2 to 4 milliliters per kilograms as boluses, or 0.5 to 1 milliliter per kilogram per hour, continuous infusion, loop diuretic use in cases of SIAD, hypervolemic hyponatremia, congestive heart failure, the use of furosemide 20 to 40 or torsemide 2.5 to 10, Zaptans in cases again of SIAD or hypovolemic hyponatremia, especially in cases of congestive heart failure, with tolvaptan use 7.5 up to 60 milligrams. Urea in SIAD conditions 15 to 60 grams per day, and SGLT2 in SIAD condition again with 10 to 25 milligrams per day. Acute hyponatremia without severe or moderately severe symptoms, what should we do? First, we should ensure that the serum sodium concentration has been measured using the same technique used for the previous measurement. There are no administrative errors. We should, if possible, stop the fluids, medication, and other factors that could be provocative for hyponatremia, and start prompt diagnostic assessment. Of course, cause-specific treatment is preferred as best strategy. If the acute decrease in serum sodium concentration exceeds 10 millimoles per liter, treat then with a single IV infusion of 150 milliliters of 3% hypertonic saline or equivalent over 20 minutes. We should check the serum sodium concentration after 4 hours using the same technique as previously done. Chronic hyponatremia without severe or moderately severe symptoms. Stop essential fluids, cause-specific treatment, mild hyponatremia. A treatment with the sole aim of increasing the serum sodium concentration is not required. In moderate or profound hyponatremia, avoid an increase in serum sodium concentration above 10 millimole per liter during the first 24 hours and above 8 millimoles per liter during the second day. In moderate or profound hyponatremia, we should check the serum sodium concentration every 6 hours until the serum sodium concentration has stabilized under stable treatment. And in cases of unresolved hyponatremia, we should reconsider the diagnostic algorithm and ask for expert advice. What in chronic hyponatremia without severe or moderately severe symptoms with the patients with expanded extracellular fluids, like in cirrhosis or congestive heart failure? We need to fluid restrict the fluid. Vasopressin receptor antagonists are not recommended, and democlocycline treatment is not recommended. In patients with SIAD, in moderate or profound hyponatremia, we should restrict fluid intake as a first-line treatment option. In moderate or profound hyponatremia, an equal second-line treatment should be considered as increasing solute intake with 0.25 to 0.5 grams per kilogram per day of urea, or a combination of low-dose loop diuretics and oral sodium chlorides should be administered. In moderate or profound hyponatremia, we recommend strictly against lithium or demeclocycline, and in moderate and profound hyponatremia, vasopressin receptor antagonists are not required. Patients with reduced circulating volume restore the extracellular volume with the infusion of 0.9 regular saline or balanced crystalline solution at 0.5 to 1 milliliters per kilo per hour. Then manage patients with hemodynamic instability in an environment where close biochemical and clinical monitoring could be provided. And when there is a hemodynamic instability, we have a need for rapid fluid resuscitation that overrides the risk of an overly rapid increase in serum sodium concentration. What to do in hyponatremia, which is corrected too rapidly? Intervention for re-lowering the serum sodium is needed. If it increases above 10 millimoles per liter during the first 24 hours or above 8 millimole per liter in the second 24 hours, we should discontinue certainly the ongoing active treatment, consult the experts to discuss if it's appropriate to start an infusion of 10 milliliters per kilogram body weight of electrolyte-free water like a glucose solution over 1 hour under strict monitoring of urine output and fluid balance, and consult an expert to discuss if it's appropriate to add IV desmopressin 2 milligrams with the understanding that this should not be repeated more frequently than every 8 hours in order to prevent any bad further outcome. For the sodium deficit, why don't we correct the hyponatremia so rapidly? Because severe neurological syndrome due to local areas of demyelination called central pontine myelinolysis or smoting demyelination syndrome should be developed with the symptoms like dysarthria, dysphagia, spastic quadriplegia, and respiratory arrest, which occurs in the pollice mostly, but also in the basal ganglia, internal capsule, and cerebral cortex. And finally, there is another flow chart for hyponatremia. If there is hyponatremia, yes, then we go to treatment chart, which I was showing first one, treatment chart. And if there is no, we should see for whether there is moderately severe symptoms in this hyponatremia, yes or no. If yes, we should treat according to the first chart I showed. And if there is no such a symptom, we should consider whether it's acute or chronic hyponatremia. If acute, then again, we should treat according to the first chart. And if there is no acute hyponatremia, we go for the treatment of chronic hyponatremia with the reduction of circulating volume. If there is, then we should treat with the refilling phenomenon for the reduced circulating volume. If there is no, then we should have expanded extracellular fluid, or no. Then if we have, then we go again to the first chart in order to proceed with the treatment. So these are the references which I would like to point out for you. And of course that if we have a possibility to discuss any of your questions online, if I'm present, then we will proceed with that questions. For now, I thank you so much.
Good afternoon, everybody. Thank you very much for this kind invitation in this presentation. I'm going to explain to you how nephrology and especially dialysis is ecologically not very friendly, and how there are solutions to try to move forward from this problem. We are currently living through an era of unprecedented environmental and temperature and climate changes, particularly because all this is squeezed over a period of about 1 century. And this is very well illustrated on this slide by the red line, which is the increase in land surface temperature over the last 150 years. So as you can see, this is something that did not start 30 or 40 years ago, but at the beginning of the Industrial Revolution. But now, over the last 30 or 40 years, there is an exponential rise. And what is even more worrisome is that at the same time, in blue, also the ocean surface temperature is rising. And that means that our buffer against an increase of land surface temperature is gradually disappearing. This is leading to extreme weather circumstances. On the other hand, long periods of drought, and on the other hand, floods which are related to water bombs or to hurricanes or to typhoons, which are becoming more frequent and also more and more severe. And quite often, the two problems are occurring in the same area, like we have seen over the last few years in Spain, with first a very dry period and then floods after inundations. This is all related to environment, and the environment has an impact on health and also has an impact on kidney health and kidney disease. But there is also an exchange in the opposite direction, whereby kidney health and more specifically kidney care and more specifically dialysis is influencing the environment. And for time reasons, I will only focus during this presentation on the relationship between kidney disease and kidney treatment and the environment. Now, many of the things that I'm going to tell you today are summarized or reviewed in this paper in Nephrology, Dialysis and Transplantation, which was published in 2023 and which is a summary of everything that could be done, not everything that could be done, but many things. So there are many more details in that paper than in this presentation. People who are interested can go to that paper, which is published open access. It is also important to stress that this paper was written not only by nephrologists, but that there were also contributions by patients, by nurses, by engineers and polymer chemists. Now, if we look into the literature to compare the three modes of kidney replacement therapy, there is not very much, and I found only this paper, which was published only as an abstract, never as a full paper. On the other hand, you can find individual publications either on hemodialysis or peritoneal dialysis or transplantation, but a real comparison with the same methods of the three methods to each other does not exist. Transplantation here in this slide is illustrated in orange, peritoneal dialysis in red, and hemodialysis in blue. It's the greenhouse gas emission particularly which is displayed, and not a surprise. Transplantation is doing much better than peritoneal dialysis and hemodialysis. It's not entirely environment friendly because, of course, production of medication is chemical industry, so there is an environmental burden of industry, and on the other hand, it's also transport of the medication and the medical act, the surgical act, intensive care treatment, hospital treatment, which has a certain environmental burden. But obviously, peritoneal dialysis and hemodialysis are doing worse. A bit more of a surprise is that there is not so much difference between peritoneal dialysis and hemodialysis, because we could suppose that peritoneal dialysis for the therapeutic act is consuming less water and also less electricity, particularly for CAPD. But later on, during this talk, I'm going to explain you that there are also a number of environmental problems with peritoneal dialysis, although the almost equal level of the two in this slide is not a real fact. It's a bit distorting reality. But we should not consider peritoneal dialysis as extremely environment friendly. Now, what is the problem? If we are looking at the data for dialysis, first of all, there is an enormous problem of water consumption, and that is exceptional in healthcare. Healthcare per se is a very environment unfriendly, economical factor. But water consumption is something that is more specific to dialysis. And as you can see, one dialysis session is consuming 400 to 500 liters of water. That's much more than the spent dialysate, but it is more related to reverse osmosis reject. In fact, 2/3 is reverse osmosis reject, and only 1/3 is spent dialysate. But in most units, all of this is going into the drain system, and all that water is lost. Although reverse osmosis water has a perfect quality for household use, like toilet or bath or gardening, and even is drinkable water. Now, there is also a lot of energy energy consumption, which is resulting in CO2 production. And that is due to the fact that the pumps and the dialysis machines need to be handled. And on the other hand, there is also, and particularly the warming of the dialysate. And finally, we also have a lot of plastic waste, and that is due to the fact that everything in dialysis is single use, and that waste needs to be managed. If it is to be incinerated, then it is producing CO2. If it's going to landfill and it is plastic, then it means that its deterioration will take many, many years or even centuries. And all this may seem abstract, so therefore I made it a little bit more plastic. And if we look at the CO2 production of 1 year of dialysis all over Europe, then you can see that this CO2 emission is the equivalent of 2.5 million car trips from Brussels to Istanbul, back and forth, of course, with fossil fuel cars. If we would calculate the same Brussels-Kiev, then it would be even 3 million car trips back and forth to Kiev. For the water waste, it's again for the entire Europe. For 1 year, it is the equivalent of 10,000 Olympic swimming pools. And for the plastic waste, it is 180 million kilograms. That is the overall body weight of the inhabitants of Brussels, multiplied by 2.5. Or if you want to have it in elephants, it is 27,000 times the weight of this African elephant. Or if you want it in volume, it is 18,000 of these large trucks. So there is a huge problem. How we are going to solve it? Well, you may be surprised that I start something far away from dialysis with prevention, but the best way to forestall problems that are related to dialysis is make that it doesn't happen, or it happens less. And we have many different measures, from lifestyle now also to medication, to slow down the progression of kidney disease. But unfortunately in Europe, and I think it is the same worldwide, the investment of governments into prevention is very low. It's only 3 to 5%, and all the rest is going into care. I know we will never be able to do it without care, but there should be a shift in the investment. Now all the focus in our medical model is at the end of the spectrum, when not much can be done, and certainly nothing can be changed anymore. And there should be more focus and more investment on the early stages. And we should not forget that all these lifestyle measures also have a positive impact on the environment. If we eat more vegetables, then there is more greenery. And on the other hand, there is less meat consumption, and cattle in general, but especially red meat, which means beef, are producers of a lot of quantity of CO2 and also methane, which is even a stronger greenhouse gas. And on the other hand, take pasture, which are huge areas that could be planted with trees. So this is entirely environment unfriendly. On the other hand, taking more exercise, of course, is also decreasing CO2 production, and particularly also not eating processed food decreases the consumption and the waste of plastic. A second solution, and still we are not at the level of dialysis, is transplantation, which we discussed already before. But unfortunately, if we are looking at the uptake of transplantation throughout Europe, these are data about the European Union, but we can add a number of countries outside of the European Union, and it will make not much of a difference. The length of each bar is indicating the number of donations per million people in a year in a given country. And as you can see, between Spain, which is the highest level, and Bulgaria at the bottom, which is the lowest level, there is a more than tenfold difference in donations. So there could be a huge catch up in many countries if they bring their transplantation rate higher. Maybe not to the level of Spain, but at least to higher levels like are seen in the middle of this pack. The different colors are meaning different types of transplantation, and here also you see differences. Some countries are doing very well in deceased donation, but not well at all in living donation. Some countries do the opposite, so more living donation than deceased donation. So here also there could be improvements from country to country, like is happening at the time being in Spain, where the number of living donations now is increased dramatically. But let's focus for the rest on what really is the cause of the problem: peritoneal dialysis and hemodialysis. And in the paper in Nephrology, Dialysis and Transplantation, we summarized semi-quantitatively all the environmental problems in a comparison between hemodialysis and peritoneal dialysis. So in this table on the top, you see 4 different topics of environmental burden: water consumption, CO2 production, pollution, and waste production. And on the other hand, in the left part of the table, you see the different items: manufacturing, treatment itself, the auxiliaries for the treatment, and the transport as a source of environmental burden. The crosses are giving the severity of the environmental burden, and the comparison is each time on peritoneal dialysis above and hemodialysis below. And I have promised you that I would give you a comparison between hemodialysis and peritoneal dialysis to explain that peritoneal dialysis is not perfectly environment friendly. And here you can see that particularly in the manufacturing, as indicated by the red crosses, there is a higher burden for peritoneal dialysis than hemodialysis, which is related to the fact that there is more plastic involved, and plastic production is environment unfriendly because it is fossil fuel that is transformed into polymers, and especially also if it turns into waste, it is incinerated and it becomes CO2 again. The same for the treatment and the auxiliaries. There is more plastic involved in peritoneal dialysis, more gloves which are thrown away, etc. And then at the bottom of the table, you see that there is also a problem with transport. Of course, it costs more CO2 to transport peritoneal dialysis fluid, which is more bulky. There is more volume in 48 hours of peritoneal dialysis treatment with 18 liters of bags as compared to hemodialysis, which is only one filter and a set of tubings. And fortunately, we now have exact data on CO2 production for peritoneal dialysis. It's data from Australia. That means that they teach us something, but they cannot automatically completely be translated into the European situation. But it's a very careful study. It is analyzing the CO2 production in kilogram, in 1,000 kilogram per year per patient. And this for 6 different regions of Australia, which are displayed at the bottom of the table. Now, in the bars, you are seeing the CO2 production, on the one hand in blue related to consumables, let's say the therapeutic act, and also the manufacturing, and in orange, the transport. And then there is a comparison between automated peritoneal dialysis each time on the left and CAPD on the right. So as you can see with the blue bars, there is virtually no difference among regions between the two, for the two modalities, with a little more disadvantage for automated PD, which is logical because, of course, there is a bit more electricity consumption. But the big difference is in the orange, it is in the transport. And there are regions who are doing much worse, and that is just simply related to the fact that they are more remote from the manufacturing plant of the peritoneal fluid. Now, this emphasizes the role of transport, but also we can make a very rough comparison with hemodialysis, because the CO2 production was also analyzed for hemodialysis many years ago. Actually, that's a study from more than 10 years ago in the United Kingdom by Connor. And their CO2 production is also 4,000 per year per patient, but this study did not include transport. So roughly spoken, we can say that although it's more or less comparing apples and pears, and we should have a real comparison in the same environment and with the same methods of the two different dialysis strategies, that hemodialysis will be producing more CO2 than peritoneal dialysis. So peritoneal dialysis is more environment friendly than hemodialysis, but it is not entirely environment friendly. What can we do with dialysis itself? Well, the paper in NDT is containing much more information. I will highlight here only a few things. One is dialysis flow restriction. If you go down for dialysis flow by, say, 100 milliliters per minute, then you will consume less electricity to warm the water, and also less electricity for the pumps, and there will be less water spent. The only problem is that one is also reducing adequacy of dialysis. In general, my impression is that the impact on adequacy of dialysis is very minimal, but real exact data showing that this is the case are for the time being missing. So this is a measure that can be taken, but it needs to be done very carefully. It needs to be explained to the patient. And if the patient feels somehow unhappy about it or uncomfortable, or if there is an increase of complaints, then one has to return to a normal schedule. So this is an area that needs much more research. For the energy neutral practices, heat exchangers are very interesting. Most modern machines are heating the incoming cold dialysate by the outgoing warm dialysate. And also in waste handling, there is waste triage so that everything goes into the proper direction, incineration for what is needed to be incinerated, no incineration for the rest. And also to try to reuse certain elements like gloves, etc. And then also we are in need of more durable dialysis machines and electronics in most cases. For the time being, these are lasting only for a certain period, let's say 5 to 10 years. And if they would last for longer, that would be certainly very helpful. There is this move towards more compact dialysis systems that is taking place. And for the time being, there are a number of clinical studies ongoing with more compact systems, which are consuming only 7 or 8 liters of dialysate, and that dialysate is regenerated by a sorbent. In that case, one needs much less heating of the water and also less water volume, with as only counterpart the environmental burden of the sorbent. It's an element that needs to be studied more carefully, but we can assume that this treatment will be much more friendly for the environment. And as the clinical trials are ongoing and the first results are already known, and at least over a period of a few months, this treatment is very well supported. This could be a very valid environment-friendly alternative. And finally, we also have to move towards a more circular dialysis economy and a dialysis philosophy. There are many different ways in the future that could help to make dialysis more environment friendly, where people are working upon. There is a slide in the NDT paper that is explaining this in detail. I highlighted in blue 4 different options that seem interesting. If we go from the top to the bottom and the left to the right, I start on the left side upper with bio-based resources, that is making polymers not from fossil fuel, but from plant fuel. For instance, here the example of resinous oil or castor oil, which is produced from plants that are growing on very arid ground. So there is no competition between the biofuel making on the one hand and, for instance, the destruction of forests. So this is an option that needs to be considered, although the question is whether it will be enough to produce such a large volume of plastic as is needed for dialysis. And there is competition with many other sectors. There is dialyzer reuse, which may research in the coming years and is especially interesting if it could be done on a safe way. And there is recycling of polymers, that is breaking down polymers into their original building stones and then building them up again into polymers. So that's on the right side in the middle. The one on the right side below is biodegradable polymers, but I think that this will be much more difficult to obtain in the nearby future. Finally, we should think about energy neutral dialysis units, more solar energy consumption, more wind energy, and particularly for solar energy, most hospitals have flat roofs. So there is a huge possibility to produce own energy. And at least if I look in my own areas, this is a way of producing energy that is not enough exploited. So that brings us to the conclusion of this presentation. The environmental burden of CKD is substantial. Prevention, transplantation, and innovative dialysis should tackle this problem. In-depth research comparing several strategies is needed with the same methods in the same environment, and environmental burden should be reported for every existing and novel therapy so that consumers, patients and physicians alike can make a weighted decision based on this environmental burden. I thank you for your attention.